morning, ladies and gentlemen. Welcome to the second plenary of the SIMCON 2018. The plenary speaker actually needs no introduction, but for those of you who were not there in the morning, the next speaker we have is Senior Professor Janaka De Silva. He is the Senior Professor of Medicine at the Faculty of Medicine, University of Kelaniya, and the Director of the Postgraduate Institute of Medicine, University of Colombo. Professor De Silva will be delivering his plenary lecture on medical management of advanced cirrhosis. Over to you, sir.
Thank you and good morning. So let me start by saying that advanced cirrhosis is such a common problem that a significant proportion of these patients are managed by general physicians. And it is therefore important that the general physician should understand some of the principles that underlie its management. So the clinical indicators of advanced cirrhosis are all associated with poor outcome: intractable ascites, bacterial peritonitis, hepatorenal and hepatopulmonary syndrome, encephalopathy, recurrent variceal bleeds, and hepatocellular carcinoma. And all of these indicators correlate well with two common models that we use to predict survival: the Child-Pugh score and the MELD score, or the model for end-stage liver disease. So we are dealing with a problem that has a very poor prognosis, but there is a definitive, potentially curable curative treatment, and that is liver transplantation. And all physicians looking after patients with advanced cirrhosis should know when to refer patients for transplant assessment. And the rule should be that you should refer early when decompensation develops. And it will be a big mistake to wait until patients are moribund or they are hospitalized in a life-threatening situation. Although there is no clear cutoff for age for transplant, most transplant centers will willingly accept patients less than 70 years of age to be considered for transplant. There are two main indications for transplant. One is decompensation, child class B or C, or a MELD score of equal to or more than 15. And these scores can be a little lower for some specific complications of advanced cirrhosis, though they are rare, like intractable pruritus, recurrent cholangitis, or hepatopulmonary syndrome. The second important indication for liver transplant is hepatocellular carcinoma, and here there are clearly laid criteria as to when you should transplant a patient, and they are called the Milan criteria. And they say if you have one lesion less than 5 centimeters in diameter, or no more than 3 lesions which are less than 3 centimeters each, when there is no macrovascular invasion or extrahepatic disease, these people may be suitable for transplantation. In a rather simple but impressive, and for me, a very practical approach, a group led by D'Amico in 2006 actually tried to stage cirrhosis using 3 very easy variables: varices, variceal bleeding, and ascites. And in this table, you can see in the last column, you can see if a cirrhotic patient has no varices, no bleeding, and no ascites, they have a very low 1-year mortality. Whereas if they have all 3, there's nearly a 60% mortality. So they suggested that anyone at stage 3 or above should be sent for transplant assessment. So basically what all these models are saying is that when a patient with compensated cirrhosis becomes decompensated, get a transplant assessment. But there are contraindications, as you know: severe cardiac or pulmonary disease, alcohol addiction without any motivation for abstinence, hepatocellular carcinoma with extrahepatic metastases, extrahepatic malignancies, sepsis, chronic infections, and so on. And lists are available at any website which will tell you absolute and relative contraindications. So what this all means is that many patients are not candidates for liver transplant, either for clinical reasons or for social and financial reasons. And even the number who qualify for transplants are far in excess of the available donor organs. The situation is so bad that nearly 15% of patients on a transplant waiting list die each year, and many more are delisted because they become too ill for liver transplant. Most of these cases, therefore, have to be managed medically. And although what we practically then do is a kind of palliative treatment for these patients with advanced cirrhosis, because we are not offering them a cure, advanced cirrhosis, surprisingly, has only recently been the focus of palliative care research. And best practices in palliative care for cirrhosis are still not defined like they are for malignancy or chronic pulmonary disease, and so on. And so in the next few minutes, what I would like to just go through with you is some evidence-based do's and don'ts for some of the commonly mismanaged complications of advanced liver cirrhosis. Let us start with resistant ascites and bacterial peritonitis. All patients with ascites should have a diagnostic paracentesis, regardless of coagulopathy, to look for infection. Spontaneous bacterial peritonitis leads to a very poor outcome in cirrhosis. They should be treated aggressively with intravenous antibiotics, usually third-generation cephalosporins, and all of them should be started on secondary prophylaxis on discharge, usually with quinolones. And these three graphs on your left, the first one shows that the probability of remaining free of infection and survival are both better in patients taking an antibiotic, up here, than those who were on placebo. And in the last graph, you can see that both ciprofloxacin and norfloxacin seem to be equal in their efficacy of preventing recurrent attacks. In the management of ascites itself, what a lot of people forget is the importance of sodium restriction to 2 grams a day to be combined with diuretics. However, most of these patients who have resistant or intractable ascites need serial large volume paracentesis with or without IV albumin, and that is the mainstay of therapy for most of these patients. Because of recurrent hospitalization, people have tried using indwelling peritoneal catheters, but these are not currently recommended universally because they have a higher risk of infection and bleeding and so on. It's also important to know that when you are treating intractable ascites, these patients have severe portal hypertension, and therefore low systemic blood pressure. So drugs that lower blood pressure further, like beta blockers, especially carvedilol, and ACE inhibitors, should be discontinued, even if it is temporarily so. In patients who are selected, we can consider TIPS. It's available in our country, but it's very expensive because most of the TIPS is done in the private sector. Another lesser understood complication is this condition called hepatic hydrothorax, This is the development of pleural effusions, mainly on the right side, in patients who have gross ascites. And again, the treatment is very similar to ascites. Diagnostic thoracentesis to exclude infection, and the management is with diuretics and thoracentesis in patients who develop dyspnea. And again, like in our management of chronic ascites, chronic pleural drainage with IC tubes is not recommended due to very frequent complications like bleeding. If you put in an IC tube into one of these patients, you're in trouble because you can never remove it. It will continue to drain and drain. Pleurodesis using talc and tetracycline can sometimes be used in patients with refractory hepatic hydrothorax, but the results are a bit mixed. Hyponatremia is probably the most mismanaged problem in cirrhosis that I see in my practice. It is very common in advanced cirrhosis, and what people forget is that it is a hypervolumic hyponatremia. It's dilutional. It's not due to an excess urinary sodium loss. And this flow chart will give you the reason why in patients who have portal hypertension, there is systemic vasodilatation, decreased renal blood flow leading to activation of the renin-angiotensin system, which increases sodium retention, and also an increase in non-osmotic ADH release, which results in a solute-free water retention, which is a little in excess of the sodium retention, and therefore you have a dilutional hyponatremia. Before I go on to treatment, a word of caution. Routine correction of asymptomatic and mild hyponatremia is not recommended by any of the guidelines. Indications for correction are either the development of neurological symptoms and or a sodium of less than 125 milliequivalents per liter. These are on all the guidelines, the European, the American, and the Asia-Pacific guidelines. So you don't have to treat a cirrhotic with a sodium of 126 who is having no neurological problem. They're quite used to having that level of sodium. Remember that there is no sodium depletion here. It's just that their volume, it's the water that is causing the sodium to appear low. Fluid restriction is the mainstay of treatment, starting with about 1.5 liters restriction per day, and then increasing it to even a restriction of 1 liter a day. Sodium restriction should be continued, and I want to emphasize this point because these people have ascites. And if you give these people sodium, it will make the matter worse. And I hope you understand this now by the flowchart I showed you. Administration of 3% saline, like the previous speaker said, should be considered only in exceptional circumstances when the sodium is very low despite fluid restriction. And as he also alluded, rapid correction of sodium of more than 9 milliequivalents of liter over 24 hours may lead to pontine myelinosis and seizures. So you have to be careful when you're correcting sodium. Two of the other things that can help to correct the sodium is the correction of hypokalemia, and I must confess that today is the first time that I clearly understood why that is after listening to Dr. Reno and giving intravenous albumin to correct osmolality. What about the vaptans, the vasopressin receptor blockers that can raise sodium? Tolvaptan, satavaptan, lixivaptan, available here. They are currently not recommended for use in patients with advanced cirrhosis because of the risk of liver damage. And this is a statement from the FDA as well as the European Association for Study of Liver Disease. So you should be very careful when you're trying to use vaptans in patients with cirrhosis for hyponatremia. Let's move on to hepatic encephalopathy, a chronic problem. And I love this slide. It's not mine. I got it from a lecture from the last DDW meeting. There are several grades of encephalopathy. So covert and overt. Then there is episodic, which happens less frequently than once in 6 months. Recurrent, which is more frequent, and persistent, which never get resolved. And then there is encephalopathy precipitated by a specific factor or spontaneous. So the treatment is to correct the precipitating factors. And for episodic hepatic encephalopathy, the evidence is metronidazole and lactulose. And there is now very good evidence that L-ornithine, L-aspartate intravenously helps in the acute situation. In recurrent or persistent hepatic encephalopathy, we are left with lactulose with or without rifaximin, a non-absorbable antibiotic. It has been shown to reduce recurrences by 50%. It may improve refractory hepatic encephalopathy, and it has been shown to improve cognition and coordination in minimal hepatic encephalopathy, very important because these people sometimes drive. Things like fecal microbial transplants are experimentally being tried in patients who have refractory encephalopathy, but they haven't got into routine practice yet. So one of the don'ts that I want to emphasize here is that protein restriction is not recommended in hepatic encephalopathy unless a patient is very severely protein intolerant. So 1.2 to 1.5 grams of protein per kilogram body weight should be given, and we should also look after the energy requirement. Variceal bleeding is well managed in general. Very few patients now die of an acute variceal bleeding in our country or worldwide. Acute variceal bleeding should be treated initially with terlipressin or octreotide, followed by endoscopic banding ligation. I mean, that's the gold standard. And non-selective beta blockers should be given to prevent recurrent bleeding. We all know that when they are not contraindicated. One of the beta blockers that have recently shown more promise than propranolol is carvedilol, because it also has alpha receptor antagonist properties, but with it comes some problems. So beta blockers are our friends. They have been the mainstay of treatment for portal hypertension for more than 35 years, reduces the incidence of first and recurrent variceal bleeds, carvedilol slightly better than propranolol, improves survival when portal pressure is reduced. One must remember that only 50% of patients that we start on beta blockers actually respond to them. And unless you measure portal pressure, you're not going to find out who the responders are, although recently there has been some evidence that measuring splenic stiffness, like we measure liver stiffness, may be able to give us an answer as to the responders and non-responders. But they can also be our enemies, because beta blockers can cause renal dysfunction and mortality in the presence of refractory ascites in a dose-dependent way, manifested by a decrease in mean arterial pressure. And careful dosing or discontinuation should be done in the presence of refractory ascites, as I said earlier, if there is a systolic blood pressure of less than 90, especially carvedilol, or where there is evidence of acute kidney injury. It is also to be remembered that you can restart it once the acute situation is resolved. Now, as we do better and better, as we get better and better at managing advanced cirrhosis, patients continue to live longer and longer, even with advanced cirrhosis. And one of the complications that we are seeing increasingly is hepatocellular carcinoma. It is a nasty cancer. It has the lowest survival of any cancer next to pancreatic cancer. So it's a nasty thing to get. And the way to deal with it is therefore to detect it early. Patients with cirrhosis have an increased risk of hepatoma, we know that. Screening is recommended with ultrasound of the liver with or without alpha-fetoprotein every 6 months, because surveillance will lead to early stage diagnosis, a higher rate of curative treatment, and improved survival. And the diagnosis of this tumor is confirmed by imaging, multiphase CT or MRI. It is only very, very rarely that we would need a cytology or biopsy to diagnose these tumors. And it can be dangerous because they are very vascular. Treatment modalities are available in this country: transarterial chemoembolization, radiofrequency ablation, microwave ablation, absolute alcohol injection, and these are most effective for small lesions less than 3 centimeters in size. And for patients who have extensive disease, palliation is usually with kinase inhibitors like sorafenib. Very expensive, but we can get it from the state sector, from the cancer hospital in Maharagama. And the patient's tolerance for all these treatments depends on their liver function. So people who are child class B, and I'm talking about advanced cirrhosis here, will do better on these treatments than those who are in child class C. Before I finish, let us not forget general health maintenance. I feel that all clinicians who treat these patients should regularly screen these patients for alcohol use because most of them are depressed. You should consider vaccination, especially against hepatitis A and B, which can affect the liver and lead to acute and chronic liver disease, but also for influenza and pneumococcal vaccination because it can lead to decompensation. If you find that your cirrhotic is either obese or losing weight, refer early to a dietitian. Remember not to restrict protein because they lose their muscle mass. Sleep dysfunction is very common among cirrhotics, and if you find sleep inversion, treat aggressively for hepatic encephalopathy. If not, one of the drugs that is now coming into vogue is melatonin, because benzodiazepines should not be used in sedating these patients. Most patients have sexual dysfunction, and unless they are severely hypotensive, sildenafil can be used in these patients. A lot of our cirrhotics complain of pain. And the important thing to remember is paracetamol 2 grams a day is safe. And one must avoid NSAIDs because of the risk of GI bleeding. Remember that paracetamol at this dose is quite safe. Muscle cramps is another common problem to be treated. You can use vitamin E, baclofen, chloroquine, and so on. A lot of patients complain of pruritus, and I see lots of prescriptions for antihistamines. They're simply not effective in these patients. Moisturizing cream for dry skin, or if they don't have a dry skin, then you have to use drugs like cholestyramine, naltrexone, sertraline, or ursodeoxycholic acid. Don't waste your time using antihistamines. So, Madam Chairman, ladies and gentlemen, if I just may summarize my talk, liver transplant is the only potential curative treatment for advanced cirrhosis. And although we practice some type of palliation when we are dealing with patients with advanced cirrhosis, the best practices in palliative care for cirrhosis are still not defined. And I think that's the thing that we have to do. How do we manage end-stage liver disease? How do you manage a patient who is having a hepatoma but who has a Child-Pugh score of over 15? Current medical management includes, the principles include regular monitoring, evidence-based treatment of complications, and I emphasize the evidence-based here. Do not forget general health maintenance and to inquire proactively and treat common quality of life symptoms. Thank you.
Thank you very much for that excellent presentation. Now I'd like to invite Professor Senaka Rajapaksa, the President of SLSIM, to hand over the certificate of appreciation.